Hi, my name is Ashley Walsh, and I'm going to be talking to you today about Barrigel and how to really optimize radiation therapy outcomes while using the Barrigel product. So just an overview of my center and where I'm from. I am part of Tampa General Cancer Institute. We are located in West Central Florida. At the time that we did the protocol work, we had one physician that was enrolling patients, and he is really a leader in using the Barrigel product. His name is Dr. Alexander Engelman. For staffing, we have 5 dosimetrists total spread out over a couple of different institutions. So just an overview of where our centers are as well in the Tampa, Florida area. In Tampa, we have 2 vaults. In Riverview, which is just a suburb of Tampa, we have 1 vault. We have another vault located in Hyde Park, and then 2 that are located in Brandon. The future of our center is that we are going to be adding protons in the near future, and all of our sites do have a full patient load. So first, I'm going to go into a prostate cancer overview. So this information is directly from the NCI, and in 2023, they are estimating new cases being diagnosed at 288,300, and that is going to be just shy of 15% of all cancer diagnosis. They are estimating 34,700 deaths related to prostate cancer in 2023, and that'll be 5.7% of all cancer-related deaths. The 5-year survival rate, though, is from looking from 2013 to 2019, over 97%. So when we think of treatment options, specifically radiation therapy, who's a candidate for this option? It's going to be a patient that has confirmed pathological diagnosis of cancer that is clinically confined to the prostate and surrounding tissues. It's going to be also patients who are considered a poor medical candidate for a radical prostatectomy. If they do not pass cardiac clearance, radiation is always an option for them. However, complications that arise from radiation treatment is those radiation-induced side effects. And if you remember back on the previous slide, we said that there is a 5-year over 97% survival rate. So these patients are living a long time in the disease-free survival stage. So if they have long-term side effects, it is going to live with them every day. So when we talk about side effects, they are done based on the grading scale. So a grade 1 is mild or asymptomatic. It's really just clinical observations and no intervention is indicated. Grade 2 is moderate or minimal, and local or non-invasive measures are indicated at this point. Grade 3 is severe or medically significant. And grade 4 is life-threatening consequences, urgent intervention is required. And then grade 5 is death related to that adverse event. So now we're going to switch gears a little and talk about hyperfractionation. So when we think about fractionation for radiation therapy, standard fractionation is 1.8 to 2 gray per fraction. And when we think about prostate cancer, that's going to mean they're going to receive 37 to 45 fractions total. And that is going to be spread out over 9 weeks. Versus if they are able to receive a moderate hyperfractionation regimen, you're looking at the 2.5 to 3 gray per fraction for 20 to 28 fractions total. So that shrinks that 9 weeks down to 4 to 5.5 weeks. So this hyperfractionated regimen is being increasingly utilized for prostate cancer. It is an increased convenience for these patients who are otherwise usually healthy men who want to go on living their life, and being able to bring them in for only 4 to 5.5 weeks versus 9 weeks and asking them to do that daily prep for treatment is significant. And this has been proven to be a well-tolerated regimen. So the Barrigel clinical trial. My clinic was one of the sites that participated in the first randomized FDA-reviewed prostate hyperfractionation trial. And the publication I have here is from JAMA Oncology. So this just shows the significance that it was published in JAMA Oncology, the significance of the clinical trial. So what was the purpose of the clinical trial? It was to determine the safety and effectiveness of Barrigel when used to create space between the prostate and rectum to decrease radiation dose to the rectum during radiation therapy to treat prostate cancer. So this clinical trial looked at dose acceleration. So the pros is there have been several prospective randomized trials that have shown dose acceleration improves long-term disease control outcomes. And the CHIP trial is one of those that is, most well known. The cons, however, is that dose acceleration to improve tumor control can significantly increase normal tissue dose, especially to the rectum. Rectal toxicity can be dose limiting, especially considering that anterior of the rectal wall usually unintentionally receives at least prescription dose, and usually a little more than that, up to 5% more. The effect of high rectal doses on quality of life in patients receiving prostate RT has been well documented. So what is that need for space between the rectum and the prostate? Here I'm just showing an axial slice of the prostate and the rectum, showing that proximity. The anterior rectum lies in close proximity to and sometimes abuts the posterior prostate, especially down towards the apex of the prostate, which results in at least some volume of the rectum receiving at least prescription dose to the prostate. So what are the rectal side effects related to prostate RT? The patients can have diarrhea, increased frequency and urgency of defecation, rectal bleeding, and fecal incontinence. So Chappé was really a godfather of spacing in the early 2000s, and he showed that by adding spacing, he could knock down grade 2+ toxicities to less than 10%. So hyaluronic acid, the HA gel basics, it is made from a non-animal stabilized hyaluronic acid, which is usually abbreviated as NASHA. This NASHA product is commonly used in the medical field. NASHA is designed specifically for tissue lifting with precise control and is well known in the medical dermatology field as an aesthetic filler Restylane. NASHA is similar to hyaluronic acid that is naturally present in the body, and it has been used in the medical field for over 2 decades. So it is not new to the medical field, however, it is new to the radiation oncology world. So this is a sagittal view with the spacer in place. I have the blue arrow pointing to where the spacer is placed. That's supposed to represent the Barrigel. So you can see that it has created a uniform space between the prostate and the rectum. This acts as a passive spacer. It does not do anything unless you specifically ask the optimizer to do something with that space to really help carve the dose away from the rectum. It just gives you the space, but you have to do something with it. So here is the axial slice that I showed you earlier on the left without the spacer in place, and then on the right with the spacer in place. That yellow cloud that is surrounding the prostate is supposed to represent the high dose radiation area. That cloud is not changing position between the left and right image. However, the location of the rectum is. So on the left, you can see that anterior rectal wall is getting full dose to the prostate, to that anterior wall. However, on the left, or I'm sorry, on the right, the spacer is there in place. And so now the rectum is able to move posteriorly away from that high dose radiation. So how is it inserted? It's using ultrasound guidance. Barrigel is administered as a gel that expands the space in the perirectal fat near the rectal wall. Barrigel is stable during the prostate radiation therapy treatments and begins to reabsorb after 6 months. So this is a video of how the Barrigel is inserted. You can see they put the needle into the most superior portion where they want the Barrigel to start, and then start placing the product as they pull the needle out. The benefit of the Barrigel is that you are able to go back in and really sculpt the tissue based on what you're seeing on the ultrasound video. So you really get that custom insertion and space created that is desired for that patient. So this is what the insertion looks like on ultrasound. You can see that the Barrigel is hypoecho, so it shows up dark. And then you want it to go in that perirectal fat area, which you can see that bright white rim surrounding the product, which is perfect because that shows that it is creating that space in that perirectal fat that you want. The other thing that's nice about seeing this view is that it shows how well it is visualized on insertion, to where even if sometimes you feel like you might not be able to see it perfectly on the CT scan after, you can feel confident in the track that in the space that it is creating, that it really is a nice uniform space from top to bottom. So the study design, it was a prospective, randomized, controlled, single-blinded, multi-center study. The initial was that all patients were low or intermediate risk prostate cancer, and then they were randomized either to the Barrigel arm, where they received spacer and fiducials, or to the control arm, where they received fiducials only. Both arms received the same hypofractionated radiation therapy. The randomization was 2-to-1 as well. Patients enrolled on the control arm were patients that did not receive the spacer. They were randomized to the control group, would receive the fiducial markers only. Fiducial markers and the Barrigel were injected in the same procedure, ensuring the subjects were masked to their assigned arm. So key objectives, the study designs, key objectives, there were 2 endpoints. The primary endpoint was effectiveness. The goal was achievement of a 25% reduction in the volume of the rectum receiving 90% of the prescription dose, and the prescription was 60 gray. So looking at reducing 25% to the 54 gray isodose line based on the pre-injection and immediate post-treatment CT and MRI scans. And then the secondary endpoint was safety, to show that Barrigel does not increase the incidence of acute grade 2+ GI toxicities within the first 3 months. So this is some inclusion and exclusion criteria for the protocol. Overall, I'll just let you look through it, but only things to point out is that these patients were T1 or T2, having a Gleason of less than or equal to 7 and a PSA of less than or equal to 20. And then for exclusion criteria, they had to have a prostate volume over 15 cc's and less than 90. And part of the protocol was an MRI. So if they had any reasons they could not receive an MRI, that would be an exclusion criteria as well. So patient flow through the department enrolled on the protocol. So the first thing that had to be done is baseline need to be determined. This was done by a CT and MRI simulation scans that were performed to create radiation treatment plans prior to the Barrigel injection. So that way we could understand what their dose to the rectum would be if they did not have that spacer in place. This plan was only to be used for that dosimetric evaluation and compared to future scans if they were enrolled to the Barrigel arm and got that Barrigel placement. So next, they would have the fiducial markers placed and potentially the Barrigel if they were enrolled to the investigational arm. The fiducial markers were used for image guidance, and those were required for both arms, whether you were control or investigational. But then the investigational group as well had the Barrigel injected. And again, these procedures were done at the same time, so that way the patients were not aware if they were getting just fiducials or fiducials and the Barrigel. Next, the patients would return to clinic within 3 to 10 days after that fiducial marker placement. At this appointment, they would have a treatment planning CT done. This is the one that would be used for treatment. And then they also needed to have an MRI scan completed within that 3 to 10 day window as well. Target volumes were done for both arms of the study. So there was GTV, which was the prostate, CTV, which was microscopic spread plus 1 cm of the bilateral seminal vesicles. And then the PTV was 5 to 10 millimeter expansion. This was up to each institution of what their standard was. The only requirement was that posteriorly it had to be that 0.5. So the treatment planning process happened next. The physician would contour the target volumes. If the patient was on the investigational arm, the physician would contour the target volume on both the pre and post implant scans. And then if they were on the control arm, just on that post fiducial placement scan. Dosimetry, we would create a radiation treatment plan for the same ones, that if it was investigational arm, we did a plan on both the pre and post. And if they were on the control arm, we would create one for just that post fiducial scan. So when you are, as a dosimetrist, when I'm contouring the Barrigel, or as a physician, if you're looking to try and determine where the prostate posterior border is, window leveling really helps. On the left here, on the top and bottom, I have the soft tissue preset, and then on the right, I have the liver. The bottom two images, that green contour is the Barrigel itself, so that's contoured on both. You can see it on the left. However, I feel you can see it better on the right in that liver preset window. Sometimes cerebellum window helps. It really partially depends on what your preset values are in the system of what's going to give you the best view of it. And for mine, liver does work well. I think of contouring Barrigel very similar to me as a dosimetrist of contouring the esophagus. I think anybody would be hard pressed to say they can 100% see the esophagus on every slice that they're looking at. However, you have confidence in the track of where the esophagus goes. So you contour the slice, scroll down, contour the next slice, you can see it on, interpolate, and then go back and evaluate. Does that make sense what you're looking at? You can look at it on the axial, and the sagittal helps a lot too. And then also remembering how it's inserted, that you have confidence in that track that is created, that path, that space that is created. So another thing of remembering how it's inserted is to contour it as one continuous contour. Sometimes people are tempted to want to create little tiny circles of where they feel they see Barrigel, but then not contouring the entire space. However, remembering how it's inserted and remembering the confidence we can have in that space created, the best practice usually is to go ahead and contour it as one continuous piece. So this was the protocol target and/or objectives and constraints that were used. So the things that were a little different for my clinic is that the coverage, they wanted 98%, covering 100% of the volume. And usually my clinic is more 195%, but being prostate and proximal seminal vesicles only, this was achievable, easily achievable. And then the rectum, that's the main point we're looking at. So there's multiple dose points we were looking at there, and then the bladder as well. However, we found with really utilizing that space that is created with the Barrigel, we were able to do better than these were asking. So if we look specifically at my clinic and how we planned, the first case was a 66-year-old man with low-risk adenocarcinoma, a Gleason 3+3, he had 4 out of 12 cores positive, and a prostate size of 46.88 cc's. So looking at the DVH for that patient, the pre-implant CT scan, the plan that was done on that is the squares. The post is the triangles. So here we can see the entire DVH curve has gotten better. The pre-implant did meet all the protocol guidelines, or all the protocol recommendations, requirements for the dose to the rectum. However, having that space in place, you can see how much better the post-implant DVH is. The question of the protocol was looking at the D90, or the 5400 centigrade point of how much dose the rectum, or how much of the rectum is getting that dose. So for the pre-spacer, 7.8% of the rectum is receiving 5400 centigrade. The post-implant, 0% is receiving 5400 centigrade with a max dose of actually 5304 centigrade. So significant decrease dose to the rectum on that high dose region. The next case we're looking at is a 62-year-old man with favorable intermediate risk, Gleason 3+4, 2 out of 12 cores positive, and a prostate size of 56.78 cc's. So again, this is the DBH of the pre and post. The pre on this one is the triangles and the post is the squares. I don't think anybody could argue this pre-DVH to the rectum is a bad DVH. It met all the requirements and it would be clinically, you could implement this clinically. However, when looking at it compared to what you can achieve after that Barrigel space is created, the pre-spacer, 5% is receiving the D90 or 5400 centigrade with a max point dose of 6259.2. So that really speaks to the fact of that anterior rectal wall unintentionally receives at least prescription dose and usually more. The prescription was 6,000, the max was 6259. Versus post-spacer, the D90 or the amount of the rectum receiving 5400 centigrade was 0.14 with a max point dose of 5626. So not only does the entire curve look better, that max point dose is significant to the rectum. So this is the same case we just looked at, but the axial slice of it. On the left, I have the pre-spacer implant. On the right, the post-spacer implant, and that arrow is pointing to where that Barrigel placement, the contour is. So here on the left, you can see how that rectum unintentionally is going to get that full dose. However, we realized on the right, we could do more with that space that is created, that the 50% isodose line is carving up nice around the rectum, but we're not using all that real estate that we have there that's created by the Barrigel. So what we did is we created a posterior Barrigel contour that we used the Barrigel similar to our rectum, that we cropped anything that was outside of the PTV of the Barrigel by 2 millimeters. I am an Eclipse user and I am a big fan of GEUED on it because it works on just kind of the entire mean dose to that structure. So I put it in my optimizer with that GEUED on it, and I say, just decrease the mean dose completely to that structure. See what you can give me. Eclipse is nice as well that you can plan on the fly. So I will pause my optimizer and see how hard I can push that structure. I know I've started pushing it too hard when I either have my 100% starting to lose coverage posteriorly. I need to loosen that a little bit. And that's when I know I've pushed it about as hard as I can. So another tip we found is to decrease the size of your posterior rectum contour. Contouring the entire track of the rectum, of course, is what needs to be done. However, for the optimizer, that's not ideal. I use my VOI box and decrease where I am creating that posterior rectum, where I crop it 2 millimeters out of my PTV and do it exactly at the level of my PTV. I know again, I'm a fan of GEUEDs, which works on the mean dose of it. So if I ask for a mean dose on my entire track of my rectum, it's going to go the path of least resistance and give me really low dose above and below, but not really push that dose at the level of the prostate the way I want it to. So if I give it a smaller amount of information to work with, it is forced to give me the dose curve I want at the level I want. So another tip we found is here, the dark blue line is my 90% isodose line, and that purple is my 50%. Anywhere scrolling up and down axial through your PTV of your prostate, you should be able to measure the distance between these two. And if you have something that is more than 10 millimeters, I would argue you could probably push that harder. And a lot of times it is done by going back in and adding contours, looking on your sagittal slices. Anywhere you see that 50% starting to bow out, go back in and add a contour at that level and specifically push that. So the results of the trial. There was 201 randomized subjects, 136 to the Barrigel arm and 65 to the control arms. Again, they were randomized 2-to-1, and this was done over 13 sites. So this is a DVH graph showing the pre and post for every patient that was enrolled on the clinical trial that was on the investigational arm. You can see that the pre and post, there is a significant difference once the Barrigel is in place of how much rectal sparing is able to be achieved. And then finally here, this is the average of all the patients that were enrolled. So looking at the results of the spacing specifically. So this is defined as the space from midline of the prostate to the rectal wall. On the left, up and down, I have a pre-Barrigel images, and then on the right is the post-Barrigel. These are fused with an MRI, which is why the contrast looks a little different. But 12.9 millimeters immediate post-injection is what was averaged, with 12.6 millimeters 3 months post-injection. The secondary endpoint was safety. And so Barrigel was shown to be superior in the reduction of acute grade 2+ GI toxicities within 3 months compared to the control subjects. So here, the graph on the right here, when you look at proctitis, for instance, 1 patient on the Barrigel arm had it versus 4 on the control arm. That doesn't seem like that big of a number until you remember they were randomized 2-to-1. So you're looking at, overall, the grade 2+ was 2.9 to just shy of 14% on the control arm. So the conclusions. HA spacer significantly reduces rectal dose if you push the optimizer to ensure you are gaining that extreme rectal sparing. Again, that space acts passive. So unless you specifically do something with that space given, you're not really utilizing up to its full potential. Contouring does take a little patience and has a small learning curve initially. But once you get over that initial hump and remember how it's inserted, make sure everybody in your clinic sees either videos or in clinic itself of the insertion so they understand the track that is created, that space, how uniform it is and how well it is seen during implant really helps everybody in the department understand the big picture of it. But these things are all worth it because HA spacer reduced acute grade 2+ toxicities for moderate hypofractionated radiation therapy. Thank you for your time today. If you have any questions, please feel free to reach out to me directly at the email below.